Bismillahirrahmanirrahim. Assalamualaikum everyone. So our group today will be presenting seminar on topic of schizophrenia spectrum and other psychotic disorder. And I will be the first presenter. Okay, next. So my topic will be included on definition of schizophrenia, its epidemiology, central features, and the etiology of schizophrenia. Okay, moving on for the definition. According to the Kaplan, schizophrenia is a syndrome of unknown etiology characterized by disturbance in cognition, emotion, perception, thinking, and behavior. While according to the CPG, it is a term that I used to describe a major psychiatric disorder that altered an individual perception, thought, and behavior. And according to the Oxford Handbook of Psychiatry, it is a psychotic illness that belongs to a group of disorder that are traditionally called functional psychosis. And this functional means that a disorder of the brain function with no corresponding structural abnormality. Okay, next. For the epidemiology, the incidence rates of schizophrenia it occur with a 15.2 per 100,000 population, with incidence are noted higher in male, urban and migrant population. We can further divide it into many more category. For the gender and age, the male contribute to more than 60% schizophrenia case in Malaysia, and the men they usually have early onset at age of 15 to 25, and the peak age of the patient presentation was at age of 30. For the ethnic group, which that have in Malaysia, for Malay, schizophrenic occur 54%. For the Chinese, 28%. For Indians, 9%, and the remaining other races 9%. And the third one is the marital status and occupation, where most of the patients who are single, divorced, and widow or separated, they have 80%. Among it occupy 80% among the schizophrenia patient, and 70% of them are unemployed. For the body weight, 60% of schizophrenia patients had a normal body mass index, 40% of them are overweight, and 4% of them are obese. Okay, next. And for the family history and comorbid condition, they have a total of 21.6% of patients with schizophrenia has a family history of mental illness, and 20% of them had some form of comorbidity, which consists of a substance abuse, which being the commonest cause, where 80% of them are taking cannabis, which is followed by amphetamine. And then the next one is the medical co-occurring condition, where 40% of them had co-occurring medical conditions such as diabetes mellitus and hypertension, which are more common in them. And then the last one is the care setting at the first contact, which they have slightly more than half of the patient were treated as outpatient, but more importantly, half of the patient had their first contact as inpatient. Okay, next. And then I will proceed to the central features, where according to the Kaplan, which translated the moral demens precoci, where the dementia precox are term that emphasize the change in cognition and early onset of a disorder. And this is done in order to distinguish this patient from those who underwent distinct episode of illness with alternate period of normal functioning, and it is classified which classified as having manic depressive psychosis. And another condition is called paranoia, which characterized by persistent persecutory delusions. And then according to Egan Brewer, which emphasize that term schizophrenia are replaced with dementia precox in the literature, which express the presence of schism between thought, emotion, and behavior in patients with the disorder. And the Brewer also stressed that schizophrenia need not have a deteriorating causes. Okay, next. And then according to the Kurt Snyder, which contribute to description of the first rank, and this first rank symptom attempt are used to attempt to make the diagnosis of schizophrenia, which is more reliable by identifying a group of symptoms that characterize of schizophrenia, and these symptoms are also rarely found in other disorder. Okay, and the different symptoms are including hearing thoughts spoken aloud, third person hallucination, auditory hallucination in form of running commentary, somatic hallucination, thought withdrawal or insertion, thought broadcasting, delusional perception, feeling or action experienced as made or influenced by external agent. Okay, next. And then other central feature, which is the positive symptom, that reflect the presence of mental features that are not normally present. And these symptoms are delusion, hallucination, disorganized speech, thinking, which consists of a thought disorder or loosening of association, grossly disorganized behavior, catatonic behavior, and other symptoms such as affect inappropriate to the situation or stimuli, unusual motor behavior such as pacing and rocking, depersonalization, derealization, and somatic preoccupation. And then the next one is the negative symptom, which is the negative symptom will be include inability, where patient had inability to show emotion, apathy, difficulty of talking, and withdrawing from the social situation. And and the patient will presented with effective patterning, where they will have a reduction in range and intensity of emotion expression, facial expression, voice tone, eye contact, and body language. And then alogia or poverty of speech, where patient will have lessening of speech, fluency, and productivity, thought to reflect slowing or block thought, and other manifest as short, empty replies to the question. And the next one is the evaluation. There will be reduction, difficulty or inability to initiate and persist in goal-directed behavior. For example, patient will have no longer interested in going out or meeting with friends. They will also will be no longer interested in activity where they used to show altruism for, and patient also had no longer interested in much of anything, where patient will usually will be sitting in the house for many hours a day by doing nothing. And then the last one for the negative symptom, which is less obvious and often persists even after the resolution of the positive symptom. Okay, next. And then we have the cognitive symptom, where patient will have difficulty with concentration and memory. And this consists of disorganized thinking, slow thinking, difficulty of understanding, poor concentration, poor memory, difficulty of expressing thought, difficulty of integrating thought, feeling, and behavior. Okay, next. And then I will move to the etiology, which the etiology of schizophrenia can be due to neurodevelopmental, genetic factor, and biochemical factor. For the neurodevelopmental, the schizophrenia may be disorder uh, based on neurodevelopmental, where we can see due to the excess of obstetric complication and those who develop the disorder. The second one is the affected subject will have a motor or cognitive problem which precede to the onset of the illness. And the third one, schizophrenic subject also have abnormality of cerebral structure at the first presentation. And then schizophrenic have a dermatoglyphic and dysmorphic feature. Okay, next. this is other evidence that support the neurodevelopmental, where the first one, the epidemiology evidence that suggests early life exposure, where there will be increased risk of schizophrenia in those who are born during winter or spring, born in urban compared to the rural setting, in utero during influenza epidemic, in utero during famine, and those who had pregnancy and birth complication, such as resource incompatibility. And the next one is the somatic physical evidence that suggests the prenatal disruption, where there will be increased risk of schizophrenia in those with more minor physical anomaly, more dermatoglyphic features. And then the evidence of longitudinal study, where the prior to the onset of disorder, individual who are later develop schizophrenia will deviated on the range of ability, including later walking, language difficulty, poor motor skill, and teacher and self-reported change in the social behavior. And the last one is the neuropathological changes, where compared to the in neuropathological changes, compared to the healthy individual, schizophrenic patient will have ventriculomegaly, smaller temporal lobe, abnormal septum pellucidum, cytoarchitecture abnormality, absence of gliosis, and then genetic position of chronic studies. Okay, next. The next one is the genetic factor, where genetic it will contribute to some or perhaps all form of schizophrenia, and a high of proportion of variants of liability to the schizophrenia, which due to the additive genetic effect, and the likelihood of a person having schizophrenia is correlate to with the closeness of the relationship to affected relatives, such as first degree or second degree relative, and this is seen in person patient who had parent with mental illness have 6% to develop schizophrenia, and for the sibling 9%, children 30%, dizygotic twin 7%, children with two affected parents 46%, and those who are monozygotic twin, they with mental illness had increases of developed schizophrenia 48%. And the mode of genetic transmission in schizophrenia are unknown. However, there is several genes that appear to make contribution to the schizophrenia vulnerability. Okay, and this is the example of the genes that lead to the schizophrenia vulnerability, which you can read by yourself later. And then the biochemical factor, which is the dopamine hypothesis, where the simple formulation of the dopamine hypothesis of schizophrenia patient, where the schizophrenia are result from too much dopaminergic activity. And this excessive dopamine will release in patient with schizophrenia has been linked to the severity of positive psychotic symptom. And the dopaminergic hyperactivity can be due to too high mass release of dopamine, or too many dopamine receptor, or hypersensitivity of the dopamine receptor to dopamine, or a combination of this mechanism. And this theory evolved from two observations, where the first is the efficacy and the potency of many antipsychotic drugs, such as dopamine receptor antagonists, which are correlate with the ability to act as an antagonist of the dopamine type 2 receptor. And the second one is a drug that increase in dopaminergic activity, which usually seen in cocaine, amphetamine, and which are psychotomimetic. And the next biochemical factor is serotonin, where the pathway of affected in schizophrenia, which can be seen into the first one is the projection for the dorsal raphe nucleus to the subsection nigra, and the second one is the projection of the dorsal raphe nucleus, which ascend into the cerebral cortex, limbic region, and basal ganglia. And this 5-HT2A receptor agonist will inhibit the dopamine release. And due to the excess of serotonin that are produced by this two pathway will cause reduction in the availability of dopamine, which gives rise to the negative symptom of schizophrenia. And these are the remaining biochemical factor, which is the first one is the glutaminergic hypoactivity, where the N-methyl diaspartate receptor antagonists have been shown to induce both positive and negative symptoms of schizophrenia in healthy volunteer, and it also exacerbates the symptom in patients with schizophrenia. However, the effect of ketamine are reduced by antipsychotic medications such as clozapine, and the facilitation of the NMDA receptor function by glycine and D-cycloserine can also lead to the symptomatic improvement. And the second one is the alpha-adrenergic overactivity, where some antipsychotic also have clear adrenergic antagonism. The increased level of norepinephrine, which has been found in the cerebrospinal fluid of the patient, that cause acute psychotic symptom. And the chronic treatment with antipsychotic drug can also lead to decrease of firing rate to the locus coeruleus. And the last one is the GABA hypoactivity, where due to the loss of GABA inhibition has been shown that lead to overactivity in other neurotransmitter symptoms such as dopamine, uh, 5-hydroxytryptamine, and norepinephrine. And there is also some evidence that support the loss of GABAergic neuron in the hippocampus of the patient with schizophrenia. By using the benzodiazepine, it may increase the therapeutic effect of the antipsychotic by their GABA facilitation. Okay, that's all for me. And for my reference, I using the Kaplan, Oxford's Handbook of Psychiatry, and the CPG. Thank you.
Assalamualaikum and good evening to all. So I'm going to continue to talk regarding schizophrenia. So on my topic, I will cover regarding the diagnostic criteria, specifiers, differential diagnosis, and principle of treatment. So the first one, we will go to the diagnostic criteria. So previous presenter already said that schizophrenia is a syndrome that is characterized by disturbance of five things regarding the disturbance of cognition, the emotion, perception, thinking, and also behavior. So how basically we were going to establish the diagnosis of schizophrenia. So for the diagnostic criteria of schizophrenia, we have two diagnostic criteria. The first one is based on DSM-5. Second one is based on ICD-10. So first we will go to this DSM-5 first. So to diagnose the patient with schizophrenia, we go to point A. We need two or more of the following criteria, at least for 1 month duration, and at least one of these must be from 1 to 3. So to make diagnosis of schizophrenia, the patient need to have two out of these five criteria: delusion, hallucination, disorganized speech, grossly disorganized or catatonic behavior, or negative symptoms. So basically, the patient need to have two out of these five, and one of them need to be from the top three. They need to have delusion, hallucination, and disorganized speech. So we go to point B, how to diagnose schizophrenia. The disorder must affect the domain of patient's life in which it will impair the function of the patient impair the function of patient in the society. So it will impair the function of patient at work or during in the relationship with the patient. We go to the point C. To make the diagnosis of schizophrenia, the continuous sign of disturbance must persist for at least 6 months of period. Then we go to point D. How to diagnose schizophrenia? We need to exclude or rule out uh, any schizophrenia-like symptom. As example, schizoaffective disorder, mood disorder with psychotic features. So we need to rule out these two types of disturbance that can lead to schizophrenia-like symptoms. So we need to rule out this first before we establish the schizophrenia diagnosis. Then for point E, we also need to rule out or exclude any substance abuse or any other medical condition that can produce schizophrenia-like symptom. So the last point for the point F, if the patient have history of autism spectrum disorder, to make the diagnosis of schizophrenia, the patient need to have prominent delusion or hallucination that is present for at least 1 month period. So that is how we were going to diagnose the patient with schizophrenia based on DSM-5. All the criteria need to be met for us to make the diagnosis of schizophrenia. Next. So how we're going to diagnose the patient of schizophrenia based on ICD-10. So basically, we have two set of criteria in ICD-10. We have red line there. So basically, we have the first set of criteria. We have A, B, C, and D. So to make the diagnosis of schizophrenia, the patient must have at least one of these criteria from the first set of criteria. So the patient need to have the first one, disorder of thought possession. The patient might have thought insertion, thought withdrawal, or thought broadcasting. The point B, the patient might have delusion of control, influence, or passivity. Point C, the patient have auditory hallucination, whether it is running commentary or third-person auditory hallucination. And point D, the patient have persistent delusion of other kind that are culturally inappropriate and completely impossible. So this is the first set of criteria. And if we want to establish diagnosis of schizophrenia, the patient must have at least one of these criteria from this first set of criteria. Then we go to the below part. The second set of criteria, we have 5 criteria. To make the diagnosis of schizophrenia, we need to have at least 2 of these criteria. The first point, point E, patient have persistent hallucination in any modality. The patient have breaks or interpolation in the train of thought. Patient have catatonic behavior. The patient have negative symptom, just like the previous presenter said. The patient might have affective flattening or poverty of speech. And the last point, the patient have significant and consistent change in the overall quality of some aspect of personal behavior. So if we want to make the diagnosis of schizophrenia, the patient must have at least 2 out of these 5 criteria for at least 1 period, 1 month period. So that is basically how we were going to diagnose the patient based on DSM-5 and ICD-10. So we move to the next one for specifier. So if after we diagnose the patient with schizophrenia, we can be more specific. So basically, the specifier, we specify the schizophrenia based on the clinical symptom, the predominant clinical presentation of the patient that come to us. So for schizophrenia, we have 5 subtypes. The first one is paranoid, disorganized, catatonic, undifferentiated, and residual schizophrenia. So we will go one by one. The first one is next, paranoid schizophrenia. So basically for paranoid schizophrenia, the most salient features of the paranoid schizophrenia, the patient will present with delusion of persecution, in which the patient will think that someone or some organization are trying to harm them, are going to harm them. And second salient features is patient can present with delusion of grandeur, in which the patient think that he is special or he is the chosen one, or the patient think that he has power, not like others. So he think he is special. So the paranoid schizophrenia have 2 salient features. Patient present with delusion of persecution or delusion of grandeur. And for paranoid schizophrenia, usually the patient have first episode of illness at older age, and due to the delusion effect, the patient come with tense, guarded, reserved, and sometimes the patient can be hostile or aggressive. For the second subtype of schizophrenia, we have disorganized schizophrenia, in which characterized by marked regression to primitive, disinhibited, and unorganized behavior. So, and compared paranoid and disorganized schizophrenia, the onset of the symptom is usually occur early, before the age of 25 years old. So the symptom of disorganized schizophrenia, the patient can present to us with personal appearance is disheveled, or we can say the patient is untidy or does not care about the hygiene of itself, and their social behavior and their emotional response are inappropriate. So that's for disorganized schizophrenia. We move to the next one. The third subtype is catatonic schizophrenia, in which the classical features in which the patient have marked disturbance in the motor functions. It may involve patient can come with stupor, negativism, rigidity, excitement, or posturing. And sometimes the patient will show rapid alteration between extreme of excitement and within few seconds or within split second, the patient can come to us with stupor. That is catatonic schizophrenia, in which it is because of marked disturbance in the motor function. And for the fourth subtype, we have undifferentiated schizophrenia. So for undifferentiated, it is schizophrenia that does not have criteria for any other subtype. So we will put it under undifferentiated schizophrenia. Next. The last subtype is residual schizophrenia, in which the patient have characterized continuing evidence of schizophrenic disturbance, in the absence of complete set of active symptoms. So basically, to make it short, the patient have symptoms of schizophrenia, but it does not meet the criteria from the DSM or ICD-10 just now. So the patient can come with emotional blunting, social withdrawal, eccentric behavior, illogical thinking, and mild loosening of association. So for these are the picture. This is the picture that I got from internet that summarize the subtypes of schizophrenia. So we can see in paranoid, it dominated by delusion, whether it's persecution or grandeur. The catatonic is marked by the motor disturbance. Patient can come with rigidity, stupor, and for disorganized, the patient can come with incoherent speech, the flat or exaggerated emotion, and social withdrawal. For undifferentiated, it is type of schizophrenia in which does not fit for any other subtypes, which we put it under undifferentiated schizophrenia. For residual schizophrenia, it is no longer meet the full criteria for schizophrenia, but still the patient have shown the symptom of schizophrenia. Next. For the differential diagnosis of schizophrenia, we have a lot of variety of differential diagnosis of schizophrenia, or the patient can come with schizophrenia-like symptom. So this is some of example of differential diagnosis that patient can come with schizophrenia-like symptom. The first one is substance-induced psychosis. Certain prescribed drug, particularly steroid or dopamine agonist, can induce psychotic state, and the patient can come to us with schizophrenia-like symptom. And other than that, the psychostimulant or alcohol should always be considered. So, as example, if patient come to us with schizophrenia-like symptom, the alcohol and psychostimulant, we need to always consider that is to be the cause for psychosis. Then the second one is mood disorder with psychotic features. So the difference of mood disorder and the schizophrenia, the distinction is depend on degree and persistence of mood disorder, the relationship of hallucination or delusion prevailing to the mood. So it have relationship with the mood. As the name suggests, it have mood disorder. The third differential diagnosis is delusional disorder. It is characterized by chronic systematized paranoid delusion, but lack other symptoms of schizophrenia. And the last differential diagnosis is personality disorder. There are various personality disorder that may have some features of schizophrenia-like symptom. It, as example, the type of personality disorder is schizotypal or schizoid, in which the patient can come with schizophrenia-like symptom. So the personality disorder, the difference with schizophrenia, the personality disorder have mild symptom and the history of occurring throughout the patient's life. Basically, the patient cannot remember or cannot remember the onset when the schizophrenia-like symptom been developed. So basically, benda tu dah jadi throughout the patient's life dah. That's for personality disorder. Next. So these are other differential diagnoses, just like I told you before that differential diagnosis of schizophrenia are really wide and have a lot of variety. So these are the example that it can be divided into psychiatric and non-psychiatric. For psychiatric, medical and neurological. So this set of diagnosis can present to us with schizophrenia-like symptom. And the last part I'm going to talk about is the principal treatment of schizophrenia. So basically for principle of treatment, I divide it into pharmacological treatment and psychosocial approach. So we will go one by one. So the first one is pharmacological treatment. So basically for schizophrenia, antipsychotic drugs are used in the treatment of acute episode and also for prevention of relapse or maintenance. However, the antipsychotic drug have some limitation to their effectiveness and significant side effect of the drugs. So the first one is treatment in acute episode. We will initiate the antipsychotic medication at lower end of licensed dose range. Do not use any loading dose. If sedation is needed during the acute episode, we will use adjunctive benzodiazepine. Then we will titrate the dose within the license range, then monitoring for the effects of the antipsychotic drug and also the side effects. Our aim is we want to achieve the optimum dose with good adherence for 2 weeks. If there was no response within 2 weeks period, we will consider to change the drug. And during the acute episode also, we consider the psychological intervention whenever medication is introduced or changed. Next one is treatment for maintenance, and also we want to prevent the relapse. We will continue the medication for a year or longer. And we will ensure the dose, duration, and adherence are adequate before switching the drug. So the drug withdrawal should be gradual, and if we do drug withdrawal for the patient, the mental state of the patient should be closely monitored. And the next one is we need to monitor the adherence regularly, and side effect, we must make sure that the patient take the drugs accordingly. Then the next one is we consider depot formulation, especially in problem with adherence. So for depot formulation, I will talk about it later. And for maintenance and relapse prevention also, we always consider psychological intervention together with pharmacological therapy. So we talked before regarding the indication of antipsychotic drug for acute episode of schizophrenia and also to prevent relapse for maintenance. So what is antipsychotic drugs? So these are the name of antipsychotic drug. We have first generation, second generation, and depot injection. So these are the list of the drug that are being used as antipsychotic drug and for patient with schizophrenia. Next. So the mechanism of action of the drug, we need the first, before I go to the mechanism of action, we need to revise back regarding the biochemical hypothesis or biochemical factors for development of schizophrenia. Just like the previous presenter said that for schizophrenia, the biochemical factor, the first hypothesis is called as dopamine hypothesis, in which there is too much of dopaminergic activity. The patient can come to us with positive symptoms. So the positive symptom, like patient can come with delusion, hallucination, or disorganized thought. For the second hypothesis, the previous presenter said is the serotonin hypothesis, in which too much of serotonin will cause reduction in dopamine, and the reduction of dopamine will cause the patient will have negative symptom of schizophrenia. So the negative symptom of schizophrenia, as example, the patient have affective flattening, in which the patient are unable to express his or her emotion. The second, maybe the patient have poverty of speech and lack of motivation. So we know that the biochemical factors or biochemical hypothesis, it is because of too much of dopamine and too much of serotonin. So we, in pharmacological treatment, we will approach in that area. So the first generation of antipsychotic drug, so basically before that, so these are the general mechanism of action. But for each of the drug, it will have its own mechanism of action lah. So the first generation, as general, the first generation will block the dopamine receptor, D2 receptor, and for second line of antipsychotic drug, it will block dopamine and also serotonin receptor. But each of the drug will have its own mechanism of action. Some of the drug will also act at any other receptor, just like histamine, cholinergic. So depend on which of the drug that will be used. So this mechanism of action as general mechanism of action of antipsychotic drug. Next. So this, after we put the patient on antipsychotic drug, we will monitor the effects of the drug and also the side effect of the drug. So these are some of common side effects that are being presented in case of patient with antipsychotic drug. So the first one, the patient can come with side effect of sedation. So why antipsychotic drug can come with sedation? So basically, some of antipsychotic drug have antihistaminic effect. So as we all know, histamine control our awakeness or our awareness. So in case of antihistaminic effect, it will produce sedation to the patient. Then next, we have tardive dyskinesia. So what is tardive dyskinesia? Tardive dyskinesia can come with stiff and jerky movement of face and also body, in which the patient cannot control it. For tardive dyskinesia, why it happen in antipsychotic, it is because we need to know that dopamine, one of the function of dopamine, it will control the locomotion or for the muscle movement. So in antipsychotic drug, we will block the dopamine. So that's why the patient can come with tardive dyskinesia. Then the next one side effect is galacturia, in which we use haloperidol or risperidone. So for galacturia, dopamine also one of the function it is control the prolactin release or prolactin secretion. But in antipsychotic drug, we block the dopamine receptor, and this condition will cause increased or excessive prolactin secretion. So the patient will develop hyperprolactinemia. And this hyperprolactinemia, the patient can come to us with breast engorgement, or patient can come with galacturia itself. Then for the next one, the postural hypotension due to alpha-1 antagonist effect and weight gain. In case of serotonin receptor and histamine antagonist, the patient can come with weight gain. And the next side effect is sexual dysfunction. For sexual dysfunction, is because of blockage of dopamine, and also some of antipsychotic drug will block the cholinergic receptor agonist, in which it will prevent the peripheral vasodilation, and patient can come with erectile dysfunction. So that's why antipsychotic drug can come with sexual dysfunction. And the last side effect of antipsychotic drug is extrapyramidal side effect, in which the patient can come with tremor, slurred speech, and also akathisia. So basically, just like I told before, the dopamine, it control one of the function, it is to control the locomotion and also the muscular movement. So in case we block the dopamine, it will come with extrapyramidal side effect. Next one is treatment adherence. So basically, it is common for partial or non-adherence treatment with antipsychotic drugs. So the patient does not comply to the medication. And if it occurs, it is associated with worse outcome. So that's why we come with depot antipsychotic or long-acting injectable. So depot antipsychotic, it is introduced to deal with non-adherence or uncertain. So we don't know whether the patient take the drug or not. So we will give depot antipsychotic or long-acting injectable antipsychotic. So one of the studies show that in case of we give the patient depot injection, it are more successful than oral medication to prevent the relapse, and it is presumed that may be due to improve of compliance when compared to the oral antipsychotic drug. So we move to the last one in case of psychosocial approach. So basically, the psychosocial approach, we have many types of psychosocial approach, as you can see on the upper part of the picture. The psychosocial intervention including family therapy, cognitive behavioral therapy, cognitive remediation, art therapy, social skill training, and etc. So basically, there are a lot of psychosocial intervention, but it share the same aim. It want to enhance the interpersonal and social functioning, attenuation of symptoms, severity, and associated comorbidity. So basically, the psychosocial approach, we want the patient to have its own function in society. We want the patient have function in society, just like before the disease. Next, for psychosocial approach, the first one is family therapy, will improve the family members' knowledge and able to coping the situation of the patient. During family therapy, we will educate regarding the illness and its consequences, and also the advice on management, on how to manage the patient. So for family therapy, it is believed to improve compliance to the medication and subsequently reduce the relapse episode of the schizophrenia symptom. The next one is cognitive behavioral therapy. So basically, this which was been done is based on the rationale that positive psychotic symptoms are amenable for behavioral medication. So we will modify the patient's belief about the origin of auditory hallucination. So we try to modify the patient's belief regarding that hallucination, regarding that voice. And this condition seems that it will decrease the distress from the experiences of hallucination and also the intensity of hallucination itself. So the patient can become more okay after the therapy. All current guidelines recommend that cognitive behavioral therapy as part of integrated treatment in schizophrenia patient. The third one is cognitive remediation. In case of cognitive impairment are important determinant of poor outcome. So it is rely on the mental exercise and training to improve performance through practice. So we ask the patient to do the mental exercise and training to improve their own performance. Other than that, there are a lot more of psychosocial approach, and these are, as an example, social skill training. We teach the patient regarding the complex interpersonal skills. For exercise, we do the it believe it have effective in improving the range of symptoms, quality of life, and global functioning of schizophrenia. And the last one is art therapy. Many schizophrenia patients benefit from art therapy, which provide them with an outlet for their constant bombardment of imagery. So basically, there are a lot more of psychosocial approach that can be done for the patient of schizophrenia. So that's all from me. And these are my references. Thank you.
Bismillahirrahmanirrahim. Assalamualaikum to everyone. Today I will present about schizophreniform disorder. So in this presentation, I will present about the introduction of schizophreniform, about the diagnostic criteria, cause and prognosis, and also the differential diagnosis, and a little bit of management of schizophreniform disorder. Okay, next slide. Okay. Actually, the schizophreniform disorder is a mental disorder that diagnosed when the symptoms of schizophrenia are present for a significant portion of the time within a 1 month period and less than 6 months. Means that the symptoms of schizophrenia must be present at least 1 month period and less than 6 months to make the diagnosis of schizophreniform. And take note that the schizophreniform disorder is an acute psychotic disorder, meaning that they has a rapid in onset and lack of a long prodromal phase. Actually, the prodromal phase is the period of subclinical signs and symptoms that precede the onset of psychosis. If the disturbance is persists beyond the 6 months, the diagnosis should be changed to schizophrenia. And take note that if patient with schizophreniform disorder will return to the baseline level of functioning once the disorder has resolved, and it is usually common in adolescent and young adult and less than half as common as schizophrenia. And the causes of schizophreniform disorder is not known as for now. Take note that the relative of patients that have the schizophreniform disorder are more likely to have a diagnosis of psychotic mood disorder than the relative of patient with schizophrenia or bipolar disorder. However, relative of individual with schizophreniform disorder also have an increase of risk for schizophrenia also. Okay, next slide. Actually, the characteristic of symptoms of schizophreniform disorder are identical to those schizophrenia, and the schizophreniform is distinguished only by its difference in the total duration of the illness, including the prodromal time, active and residual phase, at least presence 1 month but less than 6 months. So according to the DSM-5, diagnosis of schizophreniform is made if a person has two or more core symptoms and one of which must be hallucination, delusion, or disorganized speech for at least 1 month. And the other cause of symptoms are gross disorganization and diminished emotional expression. And for the negative symptoms, the example of negative symptom, we use the mnemonic 4 A's. The first A is alogia, which means that patient had an increase of thought and speech productivity. Next is the avolition, means that patient had decrease of initiation of the goal-directed behavior, or known as the decrease of motivation. Next is patient usually will have a affective flattening, which is a loss of, which means patient is lost or lack of emotional expressiveness, and it is sometimes called as blunted or restricted effect. Or in the simple word, patient will have lack of emotional expressivity. And the last one is anhedonia, which is inability to feel pleasure in normal pleasurable activities. And take note that if this symptom lasts less than 1 month, the diagnosis should be the brief psychotic disorder. And if this symptom persists beyond 6 months, the diagnosis should be changed to schizophrenia. Okay, next slide. Okay. The schizoaffective disorder and depressive or bipolar disorder with psychotic feature must be ruled out to make the diagnosis of the schizophreniform, because either there are no major depressive or manic episode that occurred concurrently with the active phase symptom, or if the mood episode has occurred during active phase symptom, means that they have been present for a minority of total duration of the active and residual period of the illness. And take note that the next criteria of schizophreniform is made if the disturbance is not attributable to the physiological effect of a substance, for example, a drug abuse or medication or another medical condition. Okay, next slide. Okay, next, to determine the prognosis of schizophreniform, if patient present at least two of the following features, which is the onset of prominent psychotic symptom within 4 weeks of the first noticeable change in usual behavior or functioning. The second one is confusion or perplexity. Third one is good premorbid social and occupational functioning, and the last one is absence of blunted or flat effect. If patient present at least two of the following features, it indicate that this patient had a good prognosis. If the two or more features are not present, it indicate that patient have not have a good prognosis, which is a poor prognosis. Next slide. However, patients with schizophreniform disorder may experience a functional impairment at the time of an episode, and they are usually unlikely to report a progressive decline in social and occupational functioning. Although the negative symptoms may be present in schizophreniform, they are relatively uncommon in schizophreniform disorder, and this schizophreniform are considered as a poor prognostic features. Next slide. It's what I have mentioned before. The diagnosis of schizophreniform disorder is made under two conditions. The first one is when an episode of the illness is lasts between 1 to 6 months duration and the individual has already recovered. And the second one is when an individual is symptomatic for less than 6 months, usually required for the diagnosis of schizophrenia but has not yet recovered. So in this case, the diagnosis should be noted as a schizophreniform disorder as a provisional diagnosis because it is uncertain if individual will recover from the disturbance within a 6-month period or not. If the disturbance persists beyond the 6 months, so the diagnosis should be changed to schizophrenia. Okay, next slide. Okay, next is about the cause and prognosis of this disorder. As what I have mentioned before, the schizophreniform is lasting more than 1 month and less than 6 months, and most estimate of progression to schizophrenia is range between 6 to 80%. And the rest, what happened to the other 20 to 40% is not known. Some of the patients will have the second or third episode during which they will deteriorate into a more chronic condition of schizophrenia. However, a few may only have this single episode and then continue on their life, although it is probably have a very rare occurrence. Next slide. Okay, for the differential diagnosis, usually the duration of psychotic symptom is the one of the very important factors that distinguish schizophreniform disorder from the other syndrome. So the other differential diagnosis that can be made is schizophrenia if the symptom is persist beyond than 6 months, or brief psychotic disorder if the symptom is less than 1 month. And the next one is mood and anxiety disorder, substance-induced psychosis, or psychosis due to medical condition. And this is the differential diagnosis for the schizophreniform disorder. Okay, next slide. Okay, now I will explain a little bit of the management As for now, with schizophrenia, there are no laboratory or psychometric tests for schizophreniform disorder yet. Okay, next for the treatment. Usually, patients that come with the schizophreniform disorder usually required hospitalization to allow the effective assessment, treatment, and supervision of a patient behavior. Okay, next, the pharmacotherapy for the schizophreniform disorder is similar to that for the schizophrenia. So the psychotic symptom can be treated for the 3 to 6 month course of antipsychotic drug. At present, atypical antipsychotic drug is commonly used. For example, risperidone, olanzapine, quetiapine, and ziprasidone. And don't forget, although we already prescribe patient with antipsychotic drug, the psychotherapy is usually necessary to help patient to integrate the psychotic experience to their understanding of their minds and life. And the next one is electroconvulsive therapy, also may be indicated for some patients, especially those that have a marked catatonic or known as the depressed features. And most of the patients come with schizophreniform disorder usually will progress to full-blown schizophrenia despite of the treatment. So in those cases, a course of management is consistent with a chronic illness must be formulated. Okay, next slide. Okay, and that's all from me. And the reference that I use is DSM-5 and Medscape. Thank you.
Okay, Bismillahirrahmanirrahim. Assalamualaikum and good evening. So my name is Kamil and I will continue the seminar on schizoaffective disorder. So schizoaffective disorder, just like the name suggests, it's involving both the affective and also the schizophrenic symptom, and they are prominent within the same episode of illness, preferably simultaneously but at least within a few days of each other. So to make it simple, the schizoaffective disorder consists of psychotic symptoms of schizophrenia and also with the mood disorder. And we classify it based on the DSM-5, either a bipolar subtype or a depressive subtype. And bipolar subtype is applied if the patient had a manic episode in the part of presentation, and also a major depressive episode may also occur. And in the depressive subtype, there are only major depressive episodes are the presentation. So for the bipolar subtype, the incidence in men and women are equal and it is common in younger age group. And for the depressive subtype, the incidence is higher in women and is more common in older age group. And the lifetime prevalence is estimated to be 0.3%, and the typical age of onset for the schizoaffective disorder is the early adulthood, and the incidence is higher in female than in male. This is because due to the increase in incidence for the depressive subtype among the female. Alright, so for the risk, there will be a genetic and physiological, and among individuals with schizophrenia, there will be increased risk of schizoaffective disorder in the first degree relative. And among individuals who has a first degree relative with schizophrenia, bipolar disorder, or schizoaffective disorder will also have a higher risk for schizoaffective disorder. And the suicide risk for patients with schizoaffective will be around 5%. And the risk will be higher if there are presence of depressive symptoms. And for the prognosis, the schizoaffective disorder sits in between of the schizophrenia and mood disorder. So it's better than a schizophrenia, but it's worse than the mood disorder. And the presence of precipitating event or stressor is associated with a better prognosis. Alright, this is the most important part in the slide where we're going for the diagnostic criteria for schizoaffective disorder. So we have a few criterion. We have criterion A, B, C, and D to diagnose the schizoaffective disorder. So the clinician must accurately diagnose the affective illness, make sure it meets all the criteria of either a manic or a depressive episode, but also to determine the exact length of each episode. And this is very important, and I will explain why. So for the first criterion A, there should be an uninterrupted period of illness during which there is a major mood episode. So we need a major mood episode. either a depressive or manic, that are concurrent with criterion A of schizophrenia. So the previous presenter have thoroughly explained all the criterion A of schizophrenia. We have the delusion, hallucination, disorganized speech, grossly disorganized catatonic behaviors, and also the negative symptoms. And then we go to the criterion B. The criterion B is very important because the delusion or hallucination must be more or at least 2 weeks in the absence of major mood episode. And why it is important? Because in criterion B, it helps us to differentiate between the schizoaffective from a bipolar disorder or major depressive disorder that presented with psychotic features. Okay, because if the hallucination or delusion occur exclusively during the depressive disorder, the diagnosis would be the depressive or bipolar disorder with psychotic features. Okay, so it depends on which come up first. So in the course of in schizoaffective, there should be a delusion and hallucination first before the patient presented with major mood episode. And then, okay, so that's why it's need for more than 2 weeks to diagnose. And this will allow us to differentiate from other differential diagnoses. And then we go to the next is criterion C, where the symptoms that meet the criteria for a major mood episode are present for the majority of the total duration of the active and the residual portion of the illness. And this is also important because we need to assess the mood symptom for the entire course of the psychotic illness, and this will allow us for the changes of diagnosis, either from the schizophrenia and from the schizoaffective. So if the mood symptoms are present for only a relatively brief period, the diagnosis is schizophrenia, not schizoaffective disorder. And to make it more clear, I will give an example. So if an individual with 4-year history of active and also a residual symptom of schizophrenia now develop a depressive and manic episode, that if they are taken together, they not occupy more than 1 year during the 4-year history of psychotic illness. So the presentation will not meet the criterion C because the duration of depressive and manic episode is not major, not meet the criteria because it's not present for the majority of the total duration. It just not occupy more than 1 year because the patient had 4-year history of psychotic illness. Okay, and the last one is the common one that the criteria are present in almost all of the psychotic illness. The disturbance is not attributable to the effect of substance, either a drug abuse or a medication or another medical condition. Okay, and then just a little bit of top up here, we have the specifier where there will be an extension to the diagnosis to further clarify a disorder or illness. So as we know before, we have a schizoaffective, either a bipolar or depression type, and whether patient present with catatonia, as presented by previous presenter, catatonia feature, we have the stupor, catalepsy, and etc. And we also can see based on the cause, whether patient had a first or patient are having multiple episodes, whether with full remission or only a partial remission, and also we look for the severity. And the severity are based on the psychotic features, where the primary symptom of psychosis including the delusion, hallucination, disorganized speech, abnormal psychomotor behavior, and also the negative symptom. Okay. Right. So this is the second most important slide because I start to understand more of the criteria because of the cause of the disease itself. So the following typical pattern for schizoaffective disorder is lasted for about 6 months, where the patient will initially are having only a psychotic symptom for 2 months. Before the next 3 months, they are presented with psychotic symptom and also major depressive episode. And the last month, patient already recovered from the depressive episode and only presented with psychotic symptom in the last month. And throughout the course, you guys can see that the duration of the depressive episode was not brief relative to the total duration of the psychiatric disturbance. And thus, the presentation qualifies for the diagnosis of schizoaffective disorder, just like what we have with the criterion C. And because of the criterion C itself, the diagnosis for some patient will convert from schizoaffective disorder to another disorder. It depends on the mood, whether it become prominent or less prominent. And for the example, to make it more clear, if the individual with symptoms that clearly meet the criteria for schizoaffective disorder, but who are on further follow-up only present with residual psychotic symptom, And the diagnosis may be changed to schizophrenia as the total proportion of psychotic illness when we compare to the mood symptom become more prominent. Okay. Then we go to the next part will be the associated feature supporting the diagnosis. And I think it's quite the same with the functional consequence or the complication. And patient could presented with social and occupational dysfunction, restricted social contact and difficulties with self-care as the negative symptom may be less severe and less persistent when we compare to schizophrenia. And then the patient could also presented with anosognosia where they will be poor insight but it will be less severe and pervasive than those in schizophrenia. And then we have the increased risk for later developing the episode of major depressive disorder or a bipolar disorder. And it is possible if the mood symptom continue, although the remission of the symptom of schizophrenia means that the mood symptom are persist, although the symptom of schizophrenia already remission. Okay, and they will be also associated with alcohol and other substance-related disorder. So there are no tests or biological measures that can assist in making the diagnosis of schizoaffective disorder. Okay, we almost end of the slide. So the next one is the differential diagnosis. So the first differential will be the substance-induced psychotic disorder and also substance-induced delirium. And we can distinguish it by the fact that the substance is judged to be the etiologically related to the symptom. And then we have the most important differential diagnosis is the mood disorder with psychotic features. And if the psychotic symptom occur exclusively during the period of mood disturbance, the diagnosis would be the mood disorder with psychotic feature. And we can use the criterion B that is designed to distinguish the schizoaffective disorder from a depressive or bipolar disorder with psychotic features. Because we need to have hallucination or delusion for more or at least 2 weeks without presence of mood disorder to diagnose schizoaffective. And just remember the cause. Okay, and we have the mood disturbance, especially depression, and is commonly developed during the course of delusional disorder. However, it does not meet the criteria for schizoaffective disorder because the psychotic symptoms in the delusional disorder are restricted to a non-bizarre delusions. And therefore, they usually doesn't meet the criterion A to diagnose for schizoaffective disorder. And the last one, we have the schizophrenia. Because of the relative proportion of mood to psychotic symptoms, it can change over the course of the disturbance, and the appropriate diagnosis for individual episode may change, and just like being stated in criteria C. And if the psychotic and affective symptoms are overlapped, the diagnosis would be the affective disorder, and if the psychotic symptom presents some of the time, and in the absence of affective syndrome, the person meets criteria for either a schizoaffective disorder or schizophrenia. Okay, I hope everything is clear here. Then we go to the second last slide. We have the principle of treatment, where the mood stabilizer are the mainstay of treatment that are being used for bipolar disorder and can be also important in treating patients with schizoaffective disorder. So for depressive type, studies show that carbamazepine was more superior compared to the lithium, and for the bipolar type, there are no differences in the two agents. So in practice, these medications are used extensively alone or in combination with each other or with an antipsychotic agent. So the antipsychotic agent has been thoroughly explained by previous presenter before. And then if the patient are having a manic episode, we can treat aggressively with a dosage of a mood stabilizer in the middle to high therapeutic blood concentration range. And if patient go for the maintenance phase, the dosage can be reduced, and this is to avoid an adverse effect and potential effect on the organ system. And it also improves the ease of use and also the compliance. And last one is the many patients who are schizoaffective who have a major depressive episode. And we treat this with antidepressant. And the example being used are the selective serotonin reuptake inhibitor, and they are often being used as a first-line agent. However, we should take note that we try to not precipitate a cycle of rapid switches from depression to mania because of the use of antidepressant. Okay. The last one is the psychosocial treatment, and the patient could benefit from the combination of family therapy, social skill training, and also a cognitive rehabilitation. because of the psychiatric field have a difficulty on deciding the exact diagnosis, it can be changed from schizophrenia, schizoaffective, and the prognosis of schizoaffective disorder itself, this uncertainty must be explained to the patient to make it clear for the patient. And the range of symptoms can be vary because the patient contend with both ongoing psychosis and also varying of the mood states. So it can be very difficult for family member to keep up with the changing nature and also the need of the patient. So it need be thoroughly explained to the family member also. And the medication regime can be also complicated with multiple medication for all classes of drugs. So just to complete my slide, I also included both the ICD-10 and DSM-5. DSM-5 we have discussed. So just a little bit on ICD-10. I try to read the books, but it's quite complicated. So I take it from the Kaplan and Sadok. So it said that in the ICD-10, the criteria is definite schizophrenic and definite affective symptoms are equally prominent and present simultaneously. Okay. And the last one is we need to exclude with patient presented with separate episode of schizophrenia and affective disorder, and the episode are in the context of substance use or other medical disorder. Just quite the same with DSM. Okay. And it's classified based on depressive, manic, or mixed. Okay, you guys can see on the comparison between these two. But I didn't read a detailed one in the ICD-10 textbook because it's quite complicated compared to the DSM-5. Okay, so I think that's all from me. Most of the reference are taken from DSM-5 and top up from other books. Okay, if there are any questions, you guys can ask later on. Thank you for your attention. And there are extra notes attached in the PowerPoint. You guys can read. It's come from my commentary itself. Okay, you guys can take a look after this. Thank you. That's all from me.
Okay, Assalamualaikum and good evening everyone. So I'll be presenting on the last part, which is delusional disorder. Okay, next. Okay, by definition, delusional disorder defined as when a person cannot tell what is real from what is imagined, and the main feature of this disorder is the presence of delusion, which is unshakable beliefs in something which is untrue. Okay, these are the types of delusional disorder. Okay, the first one is erotomanic type. Which this type applies when the central theme of the delusion is that another person is in love with the individual. Okay. For example, like we think that someone in love with ourselves. Okay. Next is a grandiose type. This subtype applies when the central theme of delusion is the conviction of having some great but unrecognized talent or insight or having made some important discovery. Okay, jealous type. This subtype applies when the central theme of the individual's delusion is that his or her spouse or lover is unfaithful. It is more to like cemburu buta. Okay, next one is psychiatry type. This subtype applies when the central theme of the delusion involves the individual belief that he or she is being conspired against, cheated, spied on, followed, poisoned, or drugged, maliciously malignant, harassed, or obstructed in the pursuit of long-term goals. The fifth type is the somatic type. This subtype applies when the central theme of delusions involve bodily functions or sensations. Mixed type, this subtype applies when no one delusional theme predominates, and the last one is unspecified types. Applies when the dominant delusional belief cannot be clearly determined or is not described in the specific types. Okay, next. Okay, so this is the examples for the types just now. Okay, for erythromic, like the patient might have this kind of delusion, like the public figure is in love with me. Okay, for grandiose, I am the real celebrity. That's an imposter. Okay, jealous type, my partner is cheating and I will find proof. Next one is psychiatry, someone is trying to harm me, I have to stop them. And next one is somatic. I know I have a horrible disease. I just know it. And for a mix, it has a characteristic of several of these and unspecified, which is other type of addiction. Next. Okay, for the diagnostic criteria, we have to hear from ICD-10 and also DSM. Okay, from ICD-10, delusions constitute the most conspicuous or the only clinical characteristic. They must be present for at least 3 months and be clearly personal rather than subcultural. Depressive symptoms or even a full-blown depressive episode may be present intermittently, provided that the delusions persist at times where there is no disturbance of mood. The next one is there must be no evidence of brain disease, no or only occasional auditory hallucination, and no history of schizophrenic symptoms um, like delusions of control and thought broadcasting, and etc. Okay, so from DSM-5, the diagnostic criteria, the first one is the presence of one or more delusions with a duration of 1 month or longer. B. Criterion A for schizophrenia has never been met. Okay, hallucinations, if present, are not prominent and are related to the delusional theme, like the sensation, the somatic type just now, which is the patient might have a sensation of being infested with insects associated. Okay, next is C. Apart from the impact of delusion or its ramifications, functioning is not markedly impaired and behavior is not obviously bizarre or odd. D. If many or major depressive episodes have occurred, these have been brief relative to the duration of the delusional periods. E. The disturbance is not attributable to the physiological effects of a substance or another medical condition and is not better explained by another mental disorder such as body dysmorphic disorder or OCD. Okay, next. For the epidemiology, according to the DSM-5, the lifetime prevalence of the delusional disorder is about 0.02%. The prevalence of delusional disorder is much rare than the other conditions like schizophrenia, bipolar disorder, and other mood disorder. This may be in part due to underreporting of delusional disorder, as those with delusional disorder may not seek for mental health attention unless they are being forced by family or friends. So for the mean age of onset is about 40 years old, but the range is from 18 years old to 90 years old. The persecutory and jealous type of delusion is more common in males, while the erotomanic variety is more common in females. Next. Okay, for the etiology, okay, the first one is family studies. It is increased prevalence of delusional disorder and related personality traits in the relative of delusional disorder probands. For biological factors, neurological conditions most commonly associated with delusions are conditions that affect the limbic system and the basal ganglia. Patients whose delusions are caused by the neurological disease that does not affect the cerebral cortex tend to have complex delusions similar to those in patients with delusional disorder. Conversely, patients with neurological disorder with intellectual impairment often have simple delusions, unlike those in patients with delusional disorder. Okay, next is psychodynamic factor. Okay, hypersensitivity and feelings of inferiority have been hypothesized to lead through reaction formation and projection to delusions of superiority and grandiosity. Delusions of erotic ideas have been suggested as replacement for feelings of rejection. Critical and frightening delusions are often described as the projection of superego criticism. Somatic delusion can be psychodynamically explained as a regression to the infantile narcissistic state in which patients withdraw emotional involvement from other people and fixate on their physical selves. Next. For the cause and prognosis, some research data indicate that identifiable psychosocial stressor often accompanies the onset of disorder. Sudden onset is more common than insidious one. Person with delusional disorder is likely to be below average in intelligence, and that premorbid personality of such person is likely to be extroverted, dominant, and hypersensitive. Delusional disorder is thought to be lifelong and it is a stable diagnosis. Factors that correlate with a good prognosis are high level of occupation, social and functional adjustment, female sex, onset before the age of 30, sudden onset, short duration of illness, and the presence of precipitating factor. Patient with persecutory, somatic, and erotic delusion are thought to have a better prognosis than the patient with grandiose and jealous illusions. Next. For the differential diagnosis, the first one is OCD and related disorders, delirium, schizophrenia and schizophreniform disorder, depressive and bipolar disorder, and also schizoaffective disorder. Okay, next. Okay, for the treatment, first is hospitalization. It is necessary to complete the medical and neurological evaluation to determine the cause. And it is necessary also to assess the patient ability to control the violent impulse, such as to commit suicide or homicide. Okay, next. Okay, pharmacotherapy. In emergency, severely agitated patient should be given antipsychotic drug intramuscularly. If patient receive no benefit from the antipsychotic medication, the drug should be discontinued. And in patient who respond to the medications, the maintenance doses can be lowered down. Okay, next. Okay, these are the examples of the medication. Okay, the first one is conventional antipsychotic, which is also called as neuroleptics. It works by block the dopamine receptor in the brain. Okay, for example, like chlorpromazine, fluphenazine, and haloperidol. Okay, we also have new medication called as atypical antipsychotic drugs. It appears to be more effective to treat the symptoms of delusional disorder, and it works by blocking the dopamine and the serotonin receptor in the brain. Okay, example is risperidone and clozapine. Okay, so the medication that might be used to treat the delusional disorder include tranquilizer and antidepressant. Tranquilizer might be used if the patient has a very high level of anxiety or problems in sleeping. And antidepressant used to treat depression, which often occurs in people with delusional disorder. Okay, next. For psychotherapy, it is important to establish a relationship between the patient and the doctor, and individual therapy is more effective than the group therapy. Next. Okay, these are my references. Thank you for listening. Assalamualaikum.